This is the second year we are going to start our Deshinar CME series. Actually, what happened means last time we had our with IAP Kollam and KGMOA Kollam in association with State Academic Cell. We have already started means six or I think more than six, I guess, CME series last year. So this year also we are planning to have more CMEs under the title Deshinar series. So first of all, I would like to thank all the people who have participated in this series. And next, I am going to introduce the State Academic Cell Chairman, Dr. Deepa Madam, and IAP Kollam President, Dr. Manoj Mani, to have kind words. Madam, please.
Good evening, everyone. KGMOA State Academic Cell in the chairperson of the Likan meeting in address. Another meeting in Varan Patidilla Sandosha Rikino. Open doctors in the knowledge build up update here. Number doctors in empower chayan, number knowledge update here, etum Nalla Margam, Enola, Tiricharanita, and a number coordinated item. State district coordinate ചെയ്തുകൊണ്ട് തന്നെ വേണ്ട മിക്കവാറും എല്ലാ ടോപ്പിക്സും ഇൻക്ലൂഡ് ചെയ്തുകൊണ്ട് ഒരു വർഷത്തെ പ്ലാൻ ഉണ്ടാക്കിയിട്ട് അക്കാഡമിക് സെല്ലിന്റെ നേതൃത്വത്തിൽ ഇങ്ങനെയുള്ള CMEകൾ നടത്തുന്നത്. അതിൽ ഏറ്റവും സന്തോഷമുള്ള ഒരു കാര്യം IAP ഇതുമായിട്ട് സഹകരിച്ചിട്ട് ജനറൽ പ്രാക്ടീഷണേഴ്സിന് വേണ്ട ടോപ്പിക്സ് വെച്ചിട്ട് ഫിസിക്കലായിട്ടുള്ള ട്രെയിനിങ്ങുകളും ഇതുപോലുള്ള ഓൺലൈൻ സൂമുകളും ചെയ്യാൻ തയ്യാറായി മുമ്പോട്ട് വന്നതിലുള്ള നന്ദി ആദ്യമേ അറിയിക്കുകയാണ്. അധികം സമയം ഞാൻ കളയുന്നില്ല. പീഡിയാട്രിക് ആസ്മ മാനേജ്മെന്റ്, ലോങ് ടേം മാനേജ്മെന്റ് ആണ് ഇന്നത്തെ ടോപ്പിക്. ഡോക്ടർ കൃഷ്ണമോഹൻ നാഷണൽ അലർജി ചാപ്റ്റർ സെക്രട്ടറി ആണ്. JC പീഡിയാട്രിക്സ് മലപ്പുറത്ത് നിന്നാണ് നമ്മുടെ ഇന്നത്തെ സ്പീക്കർ. IAP ജില്ലാ പ്രസിഡന്റ് ഡോക്ടർ മനോജിനെ ഞാൻ ഈ സെഷൻ മോഡറേറ്റ് ചെയ്യാനും സ്പീക്കറെ എല്ലാ പാർട്ടിസിപ്പന്റിനുമായിട്ട് ഇൻട്രൊഡ്യൂസ് ചെയ്ത് കൊടുക്കാനായിട്ട് ക്ഷണിക്കുകയാണ്. ഓവർ ടു യു ഡോക്ടർ മനോജ്.
Thank you, madam. Respected seniors and dear friends of KGMOA and IAP. കൊല്ലം IAPയും KGMOയും ചേർന്നിട്ട് ദേശിംഗനാട് സീരീസ് എന്ന് പറഞ്ഞിട്ട് കഴിഞ്ഞ വർഷം ഒരു 4-5 പ്രോഗ്രാംസ് ചെയ്തിട്ടുണ്ടായിരുന്നു. അപ്പൊ അത് ഈ വർഷം ആദ്യമായിട്ടാണ് നമ്മൾ സ്റ്റേറ്റ് അക്കാഡമിക് സെല്ല് നമ്മള് ഡയറക്റ്റ് ഇൻവോൾവ്മെന്റിൽ ഈ ഒരു പ്രോഗ്രാം ചെയ്യുന്നത്. അപ്പോ സംസാരിച്ച് അധികം ദീർഘിപ്പിക്കുന്നില്ല. അപ്പൊ ഇന്ന് നമ്മുടെ ടോപ്പിക് ലോങ് ടേം മാനേജ്മെന്റ് ഓഫ് പീഡിയാട്രിക് ആസ്മയാണ്. അപ്പൊ ലോങ് ടേം മാനേജ്മെന്റിന് നമുക്ക് ഇന്നത്തെ സ്പീക്കർ അതിന്റെ ഏറ്റവും ആപ്റ്റ് ആയിട്ടുള്ള പേഴ്സൺ ആണ്. So I am privileged to introduce Dr. Krishna Mohan, our speaker. As madam told, he is a junior consultant pediatrics in health service from Malappuram. He did his DNB and diploma in allergy and asthma. And he is the national secretary of allergy and applied immunology chapter of Central IAP and national executive board member of respiratory chapter. And he was the chief editor of Essentials of Pediatric Allergy in 2021 and associate editor of Textbook of Pediatric Allergy by IAP, and he is the associate editor of IAP Standard Treatment Guidelines 2022. And he is well known among IAP pediatricians in Kerala, and not only in Kerala, all over India. He is is thought to be one of the experts in allergy asthma topic, and he has done so many teaching programs, and he is the faculty he's a national faculty. So with these words, I would like to introduce Dr. Krishna Mohan. Thank you for accepting our invitation, and welcome to this Deshiംഗനാട് series. Over to you, over to Dr. Krishna Mohan for the.
Thank you, Dr. Manoj. So at the outset, let me thank KGMOA, State KGMOA for this opportunity, especially Deepa Madam, Dr. Manoj, Dr. Praveen, and also IAP Kollam and all my dear friends. So let me share my screen. കാണാമോ മനോജ്?
കാണാം.
Okay. So today I will be talking about the recent changes, basically the recent changes which occurred in the latest GINA, that is the Global Initiative of Asthma 2023. So in the next 20-30 minutes, I will be talking about the long-term management of pediatric asthma. So I will be touching upon the age-based algorithms of treatment, the recent changes as per the 2023 guidelines, and finally how to step up, step down, and how to stop the treatment in pediatric asthma. So as all of us know, asthma, for our convenience and for scientific reasons, the treatment of asthma is usually dealt based upon 3 age groups: less than 5 years, 6 to 11 years, and 12 years above and others. So I will be talking about the algorithms as well as the recent changes which occurred in 2023. I will be highlighting. So starting with the age group 6 to 11 years, this is the most common age group which present before us with asthma as far as a pediatrician is concerned. So about this, as you can see, the most important thing is to assess how severe the asthma is. Whenever a patient is coming to you with symptoms of asthma, you have to ask questions: how frequent the symptoms are. So if you see in this picture, 1 minute. So if you see in this picture, start here if. So based upon the frequency of symptoms, we have to choose the step. So the so-called mild asthma, where we say the symptoms are very less or less frequent. So symptoms less than twice a month, there we are supposed to start on step 1. So till 2020, in step 1 or in the so-called mild asthma, we used to give only salbutamol inhalation as and when needed. No other drug was given. But from 2020 onwards, what happened is that now the step 1 is that low-dose inhaled corticosteroid taken whenever salbutamol is taken. So what does it mean? So when a case who is termed as a mild asthma with symptoms less than twice a month is coming to you, you have to give him 2 inhalers. One is a steroid inhaler, or let it be a budesonide or a fluticasone inhaler, and as well as a reliever inhaler which contains salbutamol or SABA. So step 1 is that whenever the patient is getting symptoms, you have to take SABA, and along with that, you have to give a low dose ICS. So both these inhalers together they have to use. That is step 1. That is when the symptoms are less than twice a month. What if the frequency of symptoms increase? The symptoms twice a month or more, but less than daily. This is the usual type of asthma which comes to us in the usual scenario, usually a less controlled case of asthma. So if suppose these symptoms are twice a month or more, then you have to give a maintenance treatment. That means you have to give treatment on a daily basis. So step 2 is daily low-dose inhaled corticosteroid. So of course, you have started the patient on budesonide inhaler or budecort inhaler. Then you tell the patient to take the inhaler daily, BD or OD based upon the severity on a daily basis. That is step 2. And step 2 itself, you can see what is called as the other controller options. These are the less preferred options. Suppose this patient is not willing to take an inhaler in the steroid, then the option is that you can give the patient a daily leukotriene receptor and antagonist. That is our montelukast. But that is a less preferred option. That is step 2. What if the patient is not improving with this? Then we go to the step 3. So step 3 is when the symptoms are on most days or waking with asthma once a week or more. That is, daily symptoms are there. Then we have to step up the treatment. So what was step 2? Step 2 was that you started maintenance with daily low dose inhaled corticosteroids. So how to step up? So in step 3, you have 3 options. Either you can increase the dose of inhaled corticosteroids. So you started with low dose. So you can make it medium dose inhaled corticosteroid. That is one option. Second option is you add a second drug. That is a LABA or a long-acting beta agonist like formoterol or salmeterol you can add. So that is a low-dose ICS LABA. That is the second option. But third option is a recent introduction which came in 2022, what is called as MART. MART means you are giving a single inhaler for treatment. You are not giving a separate reliever. So MART means you are giving a single inhaler of a combination of inhaled corticosteroid and formoterol. Let it be, I'm not supposed to tell the company name, but still I am for convenience, I'm telling, let it be Foracort. You have started the patient on Foracort. So these are the 3 options you can choose. The clinician is the person who is supposed to choose between these 3 options. So suppose the patient is not improving in step 2, there are 3 options in step 3. Either increase the dose to medium dose or add a LABA, or you start what is called as very low dose maintenance and reliever therapy. So what is this very low dose maintenance and reliever therapy? Very low dose means in budesonide and formoterol in a dose of 100 micrograms and 6 microgram of formoterol. So that is step 3. Suppose the patient is not improving with step 3, or patient is a more severe case of asthma, then you have to step up to the next stage, that is step 4. Here, the options are either you can increase the dose of inhaled corticosteroid. You can make it medium dose inhaled corticosteroid with a LABA combination. When you are using that, the reliever here is salbutamol. Or another option is that you can continue with MART by increasing the dose of MART. So in step 3, we started on very low dose MART. So in step 4, what is supposed to do is that we can make it low dose MART. So low dose MART means budesonide in a dose of 200 micrograms and formoterol in a dose of 6 micrograms. So that is step 4. And another option, another controller option at this stage is what is called as tiotropium. That is a long-acting muscarinic antagonist. Pulmonologists among us will be knowing more about it because it is a commonly used drug for COPD that you can add as a other controller option. That is step 4. Finally, to step 5. Step 5 means you have to refer for phenotypic assessment, or you have to refer to a specialist. Here you are referring to either a pulmonologist or a pediatrician who is having specialist training in asthma and allergy, or to a physician or anybody who is trained in asthma. At step 5, the different options are you can increase the dose of the combination. That is, you can make it a high dose inhaled corticosteroid LABA, or you can add some other newer drugs. So the options available here are anti-IgE or the biologicals like omalizumab. And recently, in the 2023 guideline, one new drug has been added. New drug means in this age group, it is a new drug. Previously, it was approved above the age of 12 years. But in 2023 onwards, mepolizumab, that is an interleukin-5 antagonist antibody, has been added as a preferred maintenance treatment option as a step 5. So I will come back to this again just to give an idea about what I have told. Step 1 is that low dose inhaled corticosteroid taken whenever SABA is taken. Step 2 is that you make it a maintenance treatment by giving daily low dose inhaled corticosteroid. Step 3, you have 3 options and you have to choose one among them. But the most easiest to use is the MART therapy, which uses very low dose MART. Step 4 is when you are using either a medium dose inhaled corticosteroid LABA or a low dose MART. Step 5, you have to go for phenotypic assessment and you have to refer to a specialist and you have to add on these drugs like biologicals, anti-IgE, mepolizumab, omalizumab, etc. A few words about tiotropium, which I have already told. It is a long-acting muscarinic antagonist, which is recommended from step 4 onwards in age group more than 6 years of age. And it comes as MDAs or DPAs. The dose is 9 to 18 microgram once daily. What GINA is recommending tiotropium as add-on therapy from step 4 onwards in the age group more than 6 years. So that is about the age group 6 to 11 years. Now coming to adolescents and adults, 12 years and above. So 12 years and above, previously we had only one algorithm for that, but from 2021 onwards, GINA has converted it into 2 tracks. It looks very confusing, but it is not that difficult. So on the upper part, what you are seeing is what is called as the track 1. This is the preferred track. So you are supposed to follow this. Only if you are in a resource limited setting where you cannot follow track 1, you have to follow the track 2. So I will give more importance to track 1. So what is track 1? So track 1 is this. So this is for the age group 12 years and above. Here they have combined steps 1 and 2. That means for any patient who is having symptoms less than 4 to 5 days a week, what is the recommendation? You are supposed to give them as needed low dose inhaled corticosteroid formatrol. That is, they have combined the 2 steps. Steps 1 and 2 have been combined. And any patient who is having symptoms less than 4 to 5 days a week, the recommended drug is as needed low dose inhaled corticosteroid formatrol. What if the patient is not improving with the step 1 and 2? Or what if the symptoms are there on most days or waking with asthma once a week or more? Then you have to go to the step 3. So what is step 3? In step 1 and 2, we advised low dose inhaled corticosteroid formatrol only when the patient was symptomatic or only when it was needed. But when step 3, we advise a maintenance treatment where you tell the patient to take low dose inhaled corticosteroid formatrol, for example, Foracol, on a daily basis. That is when the symptoms are there on most days or waking with asthma once a week or more. That is step 3. Suppose the patient is not getting adequate control or the patient is coming to you for the first time with this picture, that is daily symptoms or waking with asthma once a week or more or having a low lung function. Then you have to use what is called as medium dose maintenance inhaled corticosteroid formatrol. That is step 4. And step 5 options are you have to add tiotropium, or you have to send to a specialist and you can try the options like omalizumab or anti-IL-5 or anti-IL-4. Here in track 1, the reliever used is as needed low dose ICS formatrol. So track 1 is very simple for the patient. It is very patient friendly because here you are giving only one inhaler. If you are giving Foracol, that is a combination of formatrol and inhaled corticosteroid, formatrol and budesonide, you just give one inhaler, that is Foracol you are giving. If it is the patient is step 1 and 2, you tell the patient to take only when symptoms are there. Or if you have step 3 symptoms, that is symptoms on the most days or waking with asthma once a week or more, then you have to give a maintenance of low dose inhaled corticosteroid formatrol. And step 4 is medium dose inhaled corticosteroid formatrol. But you have to remember, in all these places, what is the reliever? The reliever is the same inhaler. The reliever is inhaled corticosteroid formatrol, low dose inhaled corticosteroid formatrol. Why? What is the reason for this? Formatrol is a long-acting beta agonist. At the same time, it is fast-acting also. I will come to that later. So that property of formatrol has made it a good choice for making it for March. So low dose ICS formatrol is the drug, the only drug which is used basically in the track 1, except when it comes to the step 5 where you need to add some add-on drugs. That is about track 1. This is the preferred track. So for all practical purposes, in any patient coming to you above the age of 12 years, adults as well as adolescents, you just have to remember this simple algorithm. Very easy. What is track 2? Track 2 is where you do not have a combination or whether where you are not ready to use a single inhaler, where in places where there is a resource limited setting, means the patient is not able to purchase this combination, this drug that is for affordable, is not able to buy. Then there you can you can follow track 2. In all other practical purposes, we can just follow track 1. So what is track 2? Track 2 is our old algorithm which we are following till 2021. Here, when the symptoms are less than twice a month, you tell the patient to take an inhaled corticosteroid whenever SABA is taken. And when the symptoms are twice a month or more, you tell the patient to take a low dose maintained inhaled corticosteroid. And step 3, you tell the patient to take a low dose maintenance inhaled corticosteroid plus LABA. Step 4 is medium or high dose maintenance inhaled corticosteroid LABA. Here, the basic difference, the fundamental difference here is in the reliever. Here, in this cases, you are using as needed SABA as the reliever drug. In track 1, the reliever was a combination of inhaled corticosteroid and formoterol or foratrol. But here you are using either salbutamol, and recently a recommendation has come in the 2023 guidelines. You can use either salbutamol or a combination of inhaled corticosteroid with salbutamol. Short-acting SABA with inhaled corticosteroid, a combination. Either of that is used as a reliever. And all of the steps are the same. Only difference which came in 2023 is introduction of ICS SABA as a reliever. I hope it is clear. Now coming to the final part, less than 5 years. So in less than 5 years, it is a age group of lot of confusions for the physician. So there are a lot of differential diagnosis at this age. There is a chance of an underlying alternate diagnosis like laryngomalacia or some other differential diagnosis like bronchiectasis or a congenital heart disease. Lesser the age of the child, more is a chance of having a underlying other diagnosis than asthma. To add on that, the confusion, we have different terminologies like preschool visa, under 5 visa, episodic visa, multi-trigger visa. So at the end of the day, a physician or a pediatrician is totally confused regarding how to diagnose and manage an under 5 visa. So this is a basic classification of recurrent visa less than 5 years. It can be an episodic viral visa or a multi-trigger visa. So episodic viral wheeze means the patient is presenting before you with discrete symptoms in discrete time periods, usually following a viral cold, and the patient is usually asymptomatic beyond that period. In between the period, the patient is totally asymptomatic. On the other hand, the multi-trigger visa means the patient can have different triggers, not only during viral infections, during exposure to a cold climate, during exposure to smoke, during exposure to dust. For all these conditions, the patient can develop symptoms. And in between the periods also, the patient will be, episodes also, the patient will be symptomatic. That is episodic viral disease and multi-trigger disease. So this is the latest algorithm, 2023 algorithm regarding the management of under 5 visa. So as you can see in this picture, step 1, what is step 1? So here, for step 1, there is one change which came in 2023. They are telling for step 1, there is insufficient evidence for daily control. That means in step 1, when will you use a step 1? When there is an infrequent viral wheezing and no or few interval symptoms. This is one of the commonest scenarios which come to us on a daily basis. A patient who is presenting with you with recurrent respiratory symptoms. Whenever the child is having a cold, the patient will get symptoms like asthma, PC episodes. And previously we used to say Valry for that. So infrequent viral wheezing with no interval symptoms. That is when we use step 1. So what is step 1? Step 1 means you are not giving any maintenance treatment. You are advising the patient to take a short-acting beta agonist inhaler like salbutamol only when the child is having symptoms and there is no need of any preventer. Suppose the patient is not improving with that. There can be two scenarios. One is a patient who is presenting typically like asthma, like a symptom pattern consistent with asthma and asthma symptoms not well controlled or more than equal to 3 exacerbations per year. There you can use daily low dose inhaled corticosteroid. That is, you are telling the patient to take 100 micrograms of budesonide on a daily basis for a minimum period of 3 months. Even if the symptom pattern is not consistent with asthma, but wheezing episodes recurring SABA occur frequently, that is more than 3 per year, then you can use what is called as a diagnostic trial. So what is a trial of steroids? So trial of steroid is that you are giving any patient presenting with you with recurrent respiratory symptoms, but you are not sure that it is asthma. There, as a diagnostic method, you can use a trial of steroids. So you are giving the patient 100 micrograms twice a day for 3 months. And you review the patient after 6 weeks. Suppose the patient is getting no benefit at the end of 6 weeks, you stop the medication, revisit the diagnosis, rule out other causes also. But suppose the patient is having good response at 6 weeks, you stop ICS after 3 months and follow up. So this is a trial of inhaled corticosteroids. Here, treatment is given as a therapeutic trial. It is used not only for treatment, but also for diagnosis. That is step 2, where you are using a daily low dose inhaled corticosteroid. Suppose this patient is not improving with daily low dose inhaled corticosteroid, you can increase the step of inhaled corticosteroid to double low dose inhaled corticosteroid. And finally, if the patient is not improving with step 3 also, you can refer the patient to a specialist for specialist assessment. So what are the other controller options? So daily montelukast is another other controller option at step 2. And a combination of montelukast and low dose inhaled corticosteroid is another controller option as step 3. So basically, the most important drug for under 5 visa is inhaled corticosteroid, and only from step 2 we are using it on a maintenance basis. For step 1, where there is only infrequent viral visa and all, we are using only SABA as and when needed. So that is about the treatment part. Now coming to last few slides, there are a few changes in terminologies and definitions which came in 2023. One is this. It is what is called as the anti-inflammatory reliever. So a combination of budesonide formoterol or beclomethasone formoterol or inhaled corticosteroid with salbutamol. That is a combination of this steroid with a long-acting beta agonist or a short-acting beta agonist, where the drug is having two components. One component is a reliever and second component is an anti-inflammatory action. So that is together called as what is called as AIR or anti-inflammatory reliever. This is a new term which is introduced from 2023 onwards in GINA. MART, as I already told, it is nothing but using a combination of inhaled corticosteroid and formoterol, both for maintenance and reliever as a single inhaler, is what is called as MART. So this is the property of formoterol which helps to use it as a MART. That means the onset of action is very fast. It starts action from within 3 minutes and it is having a long action up to 12 hours. And MART you can use only with budesonide formoterol or with beclomethasone formoterol. That means you cannot do MART with salmeterol, only with formoterol. Because of its fast onset of action, MART can be tried. Finally, these definitions about mild asthma, moderate asthma, and severe asthma has changed. And previously, we used to count the frequency and severity of asthma and used to tell about mild asthma, intermittent asthma, but now it is a retrospective diagnosis based upon the step at which the good control of asthma is obtained. We classify as mild asthma, moderate asthma, or severe asthma. Finally, how to follow up the patient? You have to first follow up after starting a inhaled corticosteroid or any controller is after 1 or 2 weeks. And in every visit, you have to do a symptom assessment using the asthma diary. You have to ask the pertinent questions like limitation of activities, school absenteeism, etc. And stepping up and stepping down, there can be a short-term step up or a sustained step up. Short-term step up means when during viral infections or during allergen exposure and all, you can step up for a short period. And a sustained step up when you are not getting a good control, you can double the dose or decrease the dose depending upon the symptoms score and review the response after 2 to 3 months. So when stepping down the treatment, you have to remember when the patient is on inhaled corticosteroid alone, you have to decrease at a rate of 25 to 50% reduction at 3 months interval. But suppose the patient is on a combination of inhaled corticosteroid and LABA, you reduce ICS alone by 25 to 50% and continue LABA. Please do not stop the long-acting beta agonist first as a stepping down. You decrease the dose of inhaled corticosteroid gradually, and when control is maintained at the lowest dose of ICS, then only LABA can be stopped. Finally, stopping the treatment. Suppose you get a good control for 6 months to 1 year, then that is the time when you can think of stopping the treatment. So 6 months minimum, you should get a very good control. And even if you stop the drugs, you advise the patient to continue the trigger avoidance properly. Advise home management plan in case of acute. That is very, very important step. You have to give the patient a written asthma action plan, and you tell the patient to continue the trigger avoidance and follow the patient 3 to 6 monthly for a period of 1 to 2 years. And you tell that at any period, at any time, there is a chance that the asthma symptoms may come back. It's not like you tell for any other infectious disease. So this is a chronic condition. So at any time, the patient can get symptoms, and it is not a failure that you need to restart the inhaled corticosteroid again. At this point, you have to convey very much with the patient. So thank you so much for your patient listening. If you have any doubts regarding this, the algorithms and all, to remember or to by heart, it is very difficult. So what I will tell you is that you just take printouts of these 3 algorithms from the GINA guidelines, get it laminated and keep it on your consultation table. And you can just refer at any time you want when the patient is coming to you. That will be better than rather than remembering all these things. Thank you so much.
Thank you, Dr. Krishnamohan, for a very simple and clear-cut explanation of pediatric asthma management. Now the topic is open for discussion. If you have any doubts, can clear from the speaker.
Chat box question already.
I will read. Okay. 1 minute. Am I audible?
Yes, yes.
Okay. Praveen, can you mute others? There are a lot of disturbances. Please mute.
Mute ചെയ്തിട്ടുണ്ട്.
Okay. So the first question is, most of the patients on long-term montelukast do not show improvement. Please comment. So as I already told, montelukast is a less preferred option when you treat asthma. So only when you are telling the patient to start an inhaled corticosteroid, but due to some reason, some stigma or some other reason, the patient is telling, I'm not ready to take an inhaled corticosteroid, that is the time when you can advise montelukast. You should not consider montelukast as an alternative to inhaled corticosteroid. It is very much inferior to inhaled corticosteroid as a drug option. Beyond that, from 2020 onwards, the Global Initiative of Asthma guidelines, they have specifically told that montelukast is not a safe drug. They have given an FDA box warning regarding the neuropsychiatric manifestations of montelukast, like including suicidal tendencies, suicidal ideations, anxiety disorders, and all. So far, personally, I didn't get any patient having neuropsychiatric manifestation, but I think seniors like Sukumaran sir has told that he had some patients who had these symptoms. So montelukast is not a safe drug. Only when it is really indicated, you can give. And regarding the combination also, there is a bad tendency that it is an irrationally used along with antihistamine. That is not at all advised. That is the first question. Second is, how do you use inhaled corticosteroid LABA as a reliever? How many puffs can be used? So there is a recommendation which is given as in the GINA 2020 onwards. When you are using inhaled corticosteroid LABA combination, for example, Foracort, if you are using a combination of 100 micrograms of budesonide and 6 micrograms of formoterol, the maximum number of actuations that you can use per day is 12. So that is the upper limit. But in practical purposes, when you use in our patient, maximum 2 or 4, maximum 4 extra puffs may be needed. In majority of 99% of cases, not more than that. So the upper cutoff which is recommended is total number of 12 actuations. But in practical purposes, you need not have to use that much. Next question, what do GINA guidelines say about allergy workup and immunotherapy? So this is a very controversial topic, but from 2021 onwards, GINA has cleared the confusions regarding allergy workup and immunotherapy. So GINA is telling that in any patient who are suspecting allergic asthma, you have a good history, you can do the basic allergy workup, including the allergy testing. So allergy testing is basically to look for the specific IgE. So either you can go for a skin prick test or you can go for the in vitro test like immunocap. Regarding immunotherapy, GINA is recommending immunotherapy as a other controller option from step 2 onwards, from the age group 12 years and above. So that means from adolescents and adults, you can consider immunotherapy, but specifically they have told for a specific allergen like house dust mite. So house dust mite immunotherapy is recommended by GINA from step 2 onwards. What is the minimum age to start inhalers? So actually there is no minimum cutoff. If it is really indicated, we can start at any age, but lesser the age, the efficacy will be comparatively less, as the child may not be able to use the inhaler the way you want the patient to do, because younger the kids will be crying and they won't be that much cooperative, that the breath holding that won't be possible. But even by tidal breathing in very young kids, especially less than 6 months, it will be very difficult. So there is no minimum cutoff age. Any other doubts I can take?
ഡോക്ടർ കൃഷ്ണമോഹൻ, ഡോക്ടർ ദീപയാണ് ഒരു കാര്യം ചോദിച്ചു. നമ്മള് മോണ്ടിലൂക്കാസ്റ്റ് ഏറ്റവും ഇറാഷണൽ ആയിട്ട് യൂസ് ചെയ്യുന്ന ഒരു സമയമാണിപ്പോ. കാരണം കോമ്പിനേഷൻസ് ആണ്, സെറ്റിസിൻ മോണ്ടിലൂക്കാസ് കോമ്പിനേഷൻസ് ആണ് കൂടുതൽ അവൈലബിൾ. അപ്പൊ കറക്റ്റ് ഇൻഡിക്കേഷൻസ് എന്തൊക്കെയാണ് ചൈൽഡ്ഹുഡ് ആസ്മയില്?
There is no indication to use, not even a single indication to use it as a combined drug. Combination drug ആയിട്ട് it is not at all supposed to be used. Even if you want to use it together, you can use it two separate things. So I think India or the developing countries are the only place where you get the combination drugs available. In the outside countries, you will get it separately only. So there is no indication to use it as a combination tablet or syrup. And the indication specifically for montelukast alone is when you get a case of allergic rhinitis along with asthma or an exercise-induced asthma. These are the specific indications for using montelukast. Somebody has asked what is the role of xanthophyllins and all. So the theophylline, aminophylline and all, there is a role in acute asthma. When we were doing PG and all, we used to use aminophylline very frequently. But the latest GINA guidelines is not recommending aminophylline. It is considering the low safety profile, is discouraging the use of aminophylline.
നമ്മൾ സാധാരണ ഈ OP-യിൽ വരുമ്പോഴേ നമ്മൾ ഇപ്പൊ എല്ലാരും വീട്ടിലെ നെബുലൈസർ വാങ്ങിച്ചു വെച്ച് നെബുലൈസ് ചെയ്യുമല്ലോ. അപ്പൊ ഈ അസ്താലിനും ഇപ്പൊ ലിവോളിനും ബുഡിക്കോട്ടും വെച്ചിട്ട് റെസ്പ്യൂൾസ് വെച്ചിട്ട് ചെയ്യും. അപ്പൊ അവര് ചോദിക്കും രണ്ടും കൂടെ രണ്ട് റെസ്പ്യൂളും പൊട്ടിച്ചിട്ട് കഴിഞ്ഞാൽ എത്ര സമയം നമുക്ക് ആ കോമ്പിനേഷൻ വെച്ച് യൂസ് ചെയ്യാം? സ്ഥിരം ചോദിക്കുന്ന ഒരു ക്വസ്റ്റ്യൻ ആണ്. അപ്പൊ അത്
Okay, so the minimum amount of liquid which should be present will be around 3 to 5 ml should be there for nebulization. And what is said is that when you start the nebulizer and give the nebulization, around after 5 minutes there will be a change in the quality of the sound. That is what is called the stuttering. Change in quality of sound is the end point where you put minimum 5 minutes, not more than that, maximum 5 minutes. Beyond 5 minutes, if you are giving, it won't be effective at all. And another important thing is that we are using these respules. So the respules are coming as a combination of the drug along with the saline. So it is pre-diluted. So there is no need to further dilute. That is often a common mistake is committed. Even the respules, still normal saline is added and tried. That is not recommended. You can use respule directly, provided you are using at least 3 ml.
അല്ല, നമ്മള് ഞാൻ ചോദിച്ചത് ഈ ലിവോളിനും ബുഡിക്കോട്ടും രണ്ട് റെസ്പ്യൂൾസും കൂടെ കമ്പൈൻ ചെയ്തിട്ട് നെബുലൈസ് ചെയ്യുമല്ലോ. അപ്പൊ അവര് സാധാരണ പറയുന്നത് രണ്ടും പൊട്ടിച്ചൊഴിക്കുമ്പോൾ ഒരുപാട് ക്വാണ്ടിറ്റി ഉണ്ട്. അപ്പൊ അത് ഒരു തവണ പിടിച്ചിട്ട് പിന്നെ ഒരു 4 hours കഴിഞ്ഞിട്ട് പിന്നെ പിടിക്കാമോ എന്നാണ് സാധാരണ ചോദിക്കുന്നത്.
അതങ്ങനെ പുറത്തങ്ങനെ വെക്കാതെ അത്ര അഡ്വൈസബിൾ അല്ല.
അല്ല, ജസ്റ്റ് എടുക്കുക, അത് യൂസ് ചെയ്ത് കഴിഞ്ഞിട്ട് കളയുക എന്നുള്ളതാണ്. ഓക്കെ ഓക്കെ. ചാറ്റ് ബോക്സിൽ ഒരു ക്വസ്റ്റ്യൻ കൂടെ ഉണ്ടോ?
Role of short course oral steroids. Short course oral steroids is not recommended as a replacement drug. You can say you can use short course oral steroids. As I have showed in that picture, in step 5, when the patient is not improving with any other drug, you can use short course oral steroid, but it is only after trying all other options. Only after trying all other options with the patient. It is very easy to use, it is very cheap, but it is not recommended. Somebody has asked, as montelukast is banned abroad due to its neuropsychiatric, why is it indicated allergic rhinitis with asthma? So I would make it clear, it is not banned. FDA has given a box warning. There is a possibility of these side effects if you use it for a long time. So you can use it with caution. It doesn't mean that the drug is banned. Dr. Sajesh has said, is formoterol available as a single agent, not as in? No, it is not available separately. It is available only as a combination. Some parents wait till fluid in the nebulizer is over. So should we tell to stop of that? That is what is recommended. You can tell them to stop after 5 minutes. Anything more, Manoj?
I think there is no more doubts. We will wind up the session. Sandeep undo?
സന്ദീപ്
ഉണ്ട്,
ഉണ്ടല്ലോ.
Sandeep
ഉണ്ട്.
Sandeep illa.
ഓക്കെ, ഉണ്ട് സാർ, ഉണ്ട്.
ഉണ്ട്.
ഹലോ,
അപ്പം vote of thanks.
ഓക്കെ, പറയാം. ഓക്കെ, ആക്ച്വലി ഇറ്റ് വാസ് എ വെരി ഇൻട്രസ്റ്റിംഗ് ടോപ്പിക് ആൻഡ് നമുക്ക് ഇനിയും ഇതുപോലെ കുറെ CME സീരീസ് വരേണ്ടതുണ്ട്. ഫസ്റ്റ് ഓഫ് ഓൾ ഷമോൻ സാറിന് വളരെയധികം നന്ദി, സാറിന്റെ വിലയേറിയ സമയം നമുക്കായിട്ട് ചെലവഴിച്ചതിൽ. അതുപോലെ ധാരാളം ക്വസ്റ്റ്യൻസ് നമുക്ക് വരുന്നുണ്ടായിരുന്നു. യൂഷ്വലി നമ്മുടെ OPD-യിൽ സാധാരണ കാണപ്പെടുന്ന വളരെ കോമൺ ആയിട്ട് പീഡിയാട്രിക് ഏജിൽ കാണപ്പെടുന്ന ഒരു വളരെ ഇമ്പോർട്ടന്റ് ആയിട്ട് ടോപ്പിക് ആയിരുന്നു നമ്മൾ ഡിസ്കസ് ചെയ്തത്. once again, lot of thanks from to Dr. Krishna sir. അതുപോലെ എല്ലാ വ്യൂവേഴ്സിനും എല്ലാ പാർട്ടിസിപ്പൻസിനും വളരെയധികം നന്ദി അറിയിക്കുന്നു. To Manoj Mani sir, Deepa madam, and the State Academic Cell and all the IAP and KGMOA members. Thanks a lot.
Thank you.